Hi, everybody. So the session that I will be reporting back on is a complicated case study, the comorbid patient. And the speaker is Rachel Bush-Fewer and her husband, Mark Fewer, who is the patient. And the session was a little bit more of a storytelling than it was an educational talk, but it was a very educational story. I loved the way that they were able to tell the story in terms of the medical background and then Mark's personal accounts. It was a very interesting session for me as a patient to go to. And so just to introduce Mark, he is 45 years old and has psoriasis and psoriatic arthritis. He has a very robust family history of disease. So heart disease, heart attack, psoriasis, diabetes, osteoporosis, obesity, hypertension, TIA, kidney stones, and prostate. I believe TIA is a stroke. Let me double check, but that's what I believe it is. Transient ischemic attack, which is a stroke. Okay, it's a brief stroke. So that was his family history, and this is his medical history. He has issues with his eyes called map dot fingerprint dystrophy, sleep apnea with also deviated septum, hypertension, and coronary artery disease, neurocardiogenic syncope, obesity, type 2 diabetes, erectile dysfunction, ED, calcium oxalate kidney stones, clear cell renal cell carcinoma, so cancer of the kidneys with kidney stones. And so that is just the start of it. He also had precancer of the colon, psoriatic arthritis, right-sided sacroiliitis, enthesitis, dactylitis, and fibromyalgia, psoriasis, pre-melanoma, and scoliosis. He has had triple cardiac bypass, left kidney partial nephrectomy, lithotripsy, and a corrected deviated septum. So those are his different medical procedures. I'm going to double check to see what lithotripsy is. Lithotripsy is a procedure that uses shock waves to break up stones in the kidney and parts of your ureter. Okay, so it helps to get rid of the kidney stones. So the story of this patient, he was born in 1978 in North Miami Beach. At around 12 or earlier, he developed plaque psoriasis. At 16, he developed joint pain. 17, low back pain started. And at age 19, he had a vasovagal syncope, which basically means that your heart rate and blood pressure drop and you faint. 20 to 24, increasing joint pain. 24 years old, started on etanercept. 25, increased incident of kidney stones. 26, 28, 30, trying different medications. 33, 34, hypertension. 36, started weight loss to help with a lot of his conditions. 37 and 38, they met and got married, started having some of the eye issues. 39, failed many different medications. Age 40, had diverticulitis and more kidney stones. 41, dysautonomia, sleep apnea, triple cardiac bypass, fibromyalgia. 42, dysautonomia, residual leg pain, chronic leg pain. 43, he had his sinus surgery. 44, diagnosed with diabetes, still has dysautonomia, anemia, and renal cell carcinoma. And 45, diagnosed with low testosterone. So this man has gone through a lot. And I think, a lot of us can relate, and some of us might not be able to. Our arthritis diseases are on such a spectrum that a lot of people can have a lot of comorbidities like this that are very serious and have a lot of complications and overlap, and you just feel like you're constantly dealing with something new. And I felt like that before, probably on a much smaller scale than what he has felt, but I'm sure that some of you go through similar. And so she lists off psoriatic arthritis comorbidities in general. So cardiovascular disease, which is one of the other sessions that I reported on, specifically for RA, but can also be relevant. and obesity and metabolic syndrome, sleep apnea, fatty liver disease, chronic infections, malignancy or cancer, osteoporosis, chronic pain / fibromyalgia, uveitis, IBD or irritable bowel syndrome, enthesitis, and dactylitis. So those are common psoriatic arthritis comorbidities. So this is a really interesting slide that she had here about all of the different possible comorbidities with psoriatic arthritis and the risk that it might have to affect other comorbidities or the psoriatic arthritis itself. So I think that this is a really great slide to show you. And psoriasis has another set of comorbidities. They are pretty much the same. Added at the end is mental health and quality of life. And the speaker lists a lot of ways to identify these comorbidities and all the different teams that you have to work with. So obviously with eyes, it's ophthalmology. With anything having to do with the kidneys, it's going to be a nephrologist. Sleep apnea, you may have to go to pulmonology. Basically just saying that there's going to be a lot of different teams and a lot of different practitioners that you will have to see and will have to coordinate and make sure that they're communicating. That's the biggest thing with comorbidities, is making sure that you do see all of the specialists that specialize in those specific comorbidities, and also making sure that they're all in sync to make sure that none of the treatments that they are prescribing are counter effective to the treatments that another specialist is prescribing and things like that. I was like face-to-face case study of a patient with psoriatic arthritis that has a lot of comorbidities and how that might have affected their life. One of the biggest things that she talked about was how different he was during the time where they found out that he had carcinoma, and she couldn't figure out for anything what was wrong with him, but she just knew something was wrong with him. He wasn't the same Mark that he always was. And after getting a lot of those comorbidities taken care of, including the carcinoma, getting treatment for that, he is in better health and a lot better shape and is back to being himself. And that was just recently in the past few years. And she joked about, you've already used all of your turns of giving me scares, so you just got to chill for a little bit and all those types of things. But ironically enough, she is a nurse practitioner that for rheumatology, and she does have a very unique perspective on these situations and has really helped him to be able to identify a lot of his comorbidities and not just live through them, but get them treated. And I think that's something that all of us don't have a partner that's able to do that. As patients, we have to identify and keep track of our symptoms ourselves. And sometimes we don't know exactly if something has to do with our main diagnosis that we might have or the diagnosis that we know of. And we might just shrug it off saying, oh, it's just part of my lupus, it's just part of my RA, it's just part of my Sjogren's syndrome, it's just part of my Crohn's disease. But be very mindful that it might be something else, especially if it's something that's happening over and over again. Symptom tracking is always going to be your best friend. For me, I just keep a note in my phone, and whenever something pops up, I write it down and say how long it lasted for. And then whenever I go to the doctor, I try to just bring up a few of those things to see if it warrants any further testing. But yeah, that was this session, and I really appreciated this session as a patient, having a patient there and being able to relate. And I hope that you learned something and you enjoyed this. Talk to you soon.